Many people say, well, I need to have my spine fused. How should it be done? And the answer is really depends on what your problem is, what the pathology is. That will dictate what the best approach is for a talented spinal surgeon to choose. No two patients are the same. No two operations are the same. No two pathologies are the same. And so we need to have a wide variety of options so we can best treat each situation. What we're going to talk about today is the anatomy of the spine. In the lumbar spine, we can see there are vertebral bodies with discs in between them. And this is what allows the spine to move by having a disc. It's like a flexible ligament that allows you to bend and move. But it also involves having two joints in the back. These are called the facet joints. And these facet joints with the disc form a three-legged stool at each level where you have one vertebra above, one vertebra below, then the disc and the two joints in the back which allow for dynamic motion. Well, sometimes that disc gets injured or the facet gets injured or nerves getting pinched because of arthritis or a herniation, and we need to stabilize that segment to stop that abnormal motion which is causing crippling pain and help the patient overcome. And in fact, in those cases, a spinal fusion is very successful in helping people get their lives back. So what we're going to talk about are the different approaches we can do. And traditionally, spines were fused from behind, and nowadays, more often, they're fused from the front by cleaning out the disc and putting a cage or device in that space. But there's actually three easy ways for us to approach the spine: from the back, from the side, and from the front. And we would use the different ones in different situations. But let me explain the traditional fusion. Again, the fusion is bonding one vertebra to the next, and in the back, traditionally it was done by laying bone across these structures back here. This is the lamina and spinous process, and bone would be laid across that to try to bond it together. Then later, it was tried to put it across what we call these transverse processes, these little knobs sticking out the side of the bone. Laying bone across there would lead to a fusion. The problem is these areas don't have a lot of surface area, so they have less ability to get a fusion, a successful fusion, to actually bond those bones, which is why older surgeries had poor success rates. With the understanding of the disc space or the inner body space between the vertebral bodies, we have a much more rich area for a fusion to occur. And why is that? It's because it's a bigger surface area. If we actually take a look at a model, we can see you have this entire surface area for the fusion as opposed to just a little bit of bone here or here. This area is well vascularized, so it's got blood supply, and oxygen is important for the bones to heal. And then it's also under compression, and compression stimulates the bone cells to grow and to heal. So this is a much better place for us to achieve a fusion if our goal is to actually fuse one bone to the next. And so when we're doing that, we then have to decide, are we going to do this from behind, from the side, or from the front? And the physicians that are doing this nowadays need to be trained in all these techniques so that they can pick what is right for that specific patient. No two patients are the same, no two problems are the same, no two solutions are the same. And so we have to identify the best way to solve each person's problem, which means we have to be facile with all these approaches as a modern spinal surgeon in order to give the patients the best treatment, the best options. If we look at a model, this would be an example of cages that were put into the disc space from the front. So that would be right here. And you can see these are large cases that allow us to realign the spine and fill that entire area with the supportive structure, which then the bone can grow all the way through. We also use screws and rods, where in this case, these would be put in from behind, and these screws and rods go into the bone and give us great fixation of the spine. And this acts much like a cast that you put on your arm if you break your arm to help the bones heal. You wear the cast. That's what this does. This is an internal cast which we put into the spine, and that actually holds the bones together while they heal. Once they heal, this could potentially come out, but doesn't have to. And that's something that we often do if people have symptoms around them, but they can also be left in for the patient's lifetime. Those cages in the front usually stay in permanently.